Off. Okay, so guys, we're going to talk about today. This is essentially going to cover on-field management, right, of non-concussive neurotrauma. Okay, obviously, starting next week, we're going to be talking. We're going to start our discussion on concussion, right? But um, there's a lot of crossover here between what we're going to talk about today and concussion. But the one thing that we know, right, is that there are there are certain diagnoses, right, that supersede concussion that we can't miss, right? And so it's those diagnoses that we're some of them that we're going to talk about today. All right, so when we kind of discuss non-concussive neurotrauma, but particularly, okay, on-field evaluation and management. Okay, so before we jump into this, I have a question for all of you. The last time that we've probably talked about this in any sort of detail was actually in intro. Okay, what do you remember about appropriate steps for on-field examination? What do you remember?
Airway, breathing, circulation.
Okay, bingo, number one. Okay, anybody else? Okay,
Uh,
sorry.
I was
You
just
go ahead.
gonna say, make sure they're actually responsive to you and can respond and then do your actions.
Yep, nice. Okay, very good. All right, so here's the deal. Okay, obviously, yes, that's step one, making sure they're responsive. Okay. Um, but here's if I could freaking spell symptoms. There we go. Okay, so obviously, guys, the first thing that kind of comes about, right, when we talk about obviously non-concussive neurotrauma, I think a lot of times, our brains, kind of the first thing we think about is concussion, right? But we have to have kind of a broader sense of awareness, right? When we're evaluating on the field injuries, particularly situations like this that you see in the picture, right? So this was 2S concussion. I don't remember if this was this season or last season. I don't remember if it was this year or the year before. Um, but right, this is actually not all that uncommon to see a situation like this, and we can see that obviously, you know, to his hands are kind of up near his helmet, and believe it or not, he's not doing that actually voluntarily. That's actually an involuntary response, right, after traumatic brain injury. Okay, so here's the thing, right? Ultimately, um, in the event that we are not essentially cognizant of and or careful to rule out any non-concussive neurotrauma, okay, like brain bleeds, spinal cord injury, these types of things, right? This can get us in a fair bit of trouble, right? And so we have to be very, very cognizant of the fact that while 8 or 9 times out of 10, this is likely going to be concussive, right? There's always the chance that um, there could be obviously other things going on, particularly with these types of symptoms as they're displayed. And we're going to get into these more and more and kind of talk about them, right? So these things, if we don't catch them and handle them appropriately, can have a significant effect on someone's quality of life. Can have a lot of morbidity, and God forbid, in the worst case scenario, they can kill someone, right? So obviously, two of the most kind of prominent non-concussive neurotrauma events that we think about are going to be our subdural bleeds, right? So our subdural hematomas, right, and spinal cord injury. Okay. Um, Obviously, kind of like we've mentioned and are going to kind of say a lot during this lecture, right? There can be a lot of crossover, right, between concussion and these types of symptoms. However, the one caveat that we have to really keep in mind is that of the vast majority of our concussions, as we'll learn, are not going to present with these types of centralized symptoms. Okay. So seeing concussions present with these types of centralizing symptoms are not as common. Okay, not as common. So if you see these, right, we need to have a little bit more of a broader window as far as suspicion, and even really, um, kind of a lower threshold for referral and potentially ED transport. Okay, all right. So how many of you, and I don't, I mean, all of us have probably seen this on TV. How many of you in real life though have seen this? Right, guys down on the field not moving. Right, completely and totally out. And I know, I mean, there's a lot of football pictures here, but this can happen in any sport. I had a one year had a women's basketball player. This happened actually more than once. This poor girl, God, we were at practice. It was like December 26th. Like yeah. And she went to go essentially set a pick right in the paint. She was actually a point guard. And one of our posts turned around and accidentally elbowed her, caught her uh, straight in the side of the head, and she was out before she hit the floor. Um, Literally laid there, and I shouldn't chuckle, but this poor girl, she was stiff as a board, laid there stiff as a board for probably about 10 seconds. Um, so, um, and by the time I got to her, she was up and moving around. Right. Still, we obviously still sent her off for evaluation. She got she got the mess knocked out of her. I mean, super, super sweet girl, but she got straight up. It was bad. So anyway, okay, how do we handle these types of situations? Because all of you will deal with this at some point, right? Bottom line, like we've already talked about, ABCs. We've got to check those ABCs and establish responsiveness, right? So obviously looking for breathing. Um, how do you think, guys? Let's say for example the patient is prone, all right, and you can't see chest rise that well, and you can't see their face. How are you going to position yourself to be able to check ABCs there? What would you do if they're prone?
Could you like try and listen for breathing and like listen to see if their airway in the mouth is obstructed potentially?
Okay, so Drew, I'm glad you said that. What I would do in this case, if they're prone, I generally like to approach them basically from the head, and I will lay down. I will literally lay down on my stomach. Okay, and probably, I'll lay down on my stomach, and I will actually put my head right up next to their helmet and look at them. Right? Are they responding to me? Yes or no? Do I hear breath? Right? And if I look at them, can I see chest rise? So I'll actually get next to them, laying on my stomach, and I'll put my face right next to their helmet, literally looking into their face mask and looking at their face. Right? Do I feel breath? Do I see breathing? Right? Are they talking to me? All right. So that's how I would typically do it. Um, but yeah, so, and then ultimately, there are times where they'll be responsive, and they might even roll over onto their back on their own, right? But um, if they, if they're prone and you have to move them, then obviously we need to take C-spine precautions, and have a team ready to respond, right? Okay, we know this, right? And we went over this ad nauseum in intro. We did this until we were blue in the face. Um, so obviously, if we suspect C-spine injury, we're not going to move them until we have an appropriate team in place to maintain stabilization, right, and address equipment. Now, I do know, right, that the way we learned it in intro, I'm sorry, pardon me. I do know that the way we learned it in intro, because we learned equipment removal in intro. I know that that is not Gustavus's policy. I know that that's not what you guys do downstairs. Completely and totally get that. Um, but with ultimately you've got to have trained people to be able to get that equipment off appropriately and correctly. If you're at a rural high school, right, then ultimately your first step is you're going to get that face mask off so that you have airway access in the event that breathing goes south, and they go into respiratory rest, right? So obviously, maintain stabilization, get that face mask off, right? And if you have to, obviously, if they're complaining of neurological symptoms and these types of things, then you need to activate your EAP right away and get moving. Now, question for you guys. Let's say that you have to do CPR in this kind of a situation. How are you going to open the airway? How would you do it?
Like if they're prone,
No. If they're supine, like in this case, right? So if they're prone, you got to get them on their back and open the airway, obviously, right? But in someone that maybe you suspect, like subdural bleed and or C-spine trauma, okay, how would you open the airway?
um,
We have two ways to do it. We have head till chin lift, and then we have another one. Who remembers what it's called?
are you talking about the tube you put down their throat?
No, so this is actually a jaw thrust. Do you guys remember learning the jaw thrust in CPR?
Not sure.
Okay. So here's the deal. We can actually, toward the end of the semester, we're actually going to review airway placement in people with obviously head neck injury, right? Also people with skull fractures, facial fractures. We will review all of that. So don't fret. We'll review all of it. In this case, we would do a jaw thrust. Okay, so this is actually where we lift up on the mandible and push the mouth open while lifting up on the mandible without moving the neck. Okay, so anytime, and I should have put this on the slide around the room, but here's the deal, guys. Anytime that we have this kind of a situation where they are out on the field and not moving, they might be responsive, right? But anytime they're out in the field uh, and not moving, assuming airway and circulation are intact, right, and breathing are intact, we are going to assume that there is a neck injury. Okay, we're going to assume a C-spine injury, and so we'll need to take appropriate precautions, C-collar board, the whole nine, right, and get them referred. Okay, does it make sense why we would assume that there's a neck injury even if there's not? Why would we potentially assume C-spine in this situation?
It's better to be, or better to assume and be wrong than miss it and don't.
Absolutely, because Izzy, as you've correctly stated, right, there can be many different causes for this type of situation, right? It could be a concussion. Absolutely, yes, it could be, right? But another reason why they may be, down in the field not moving is because they have a C-spine fracture. Or if it's an upper C-spine fracture, right, the neurological structure right below C1, C2 is the brainstem. That's where our breathing centers are housed, right? And so if we have a C1, C2, cervical spine fracture, and we'll talk more about that when we talk about the neck, right? There are there's a lot more involved neurologically and a lot more that can go wrong. So as you have correctly stated, we need to take precautions for any type of injury that could cause this presentation, whether it's a cervical spine fracture, whether it's a high C1, C2 fracture, right? Whether it's a concussion, or whether it's even something like a subdural bleed, right? Spinal cord injury. So ultimately, taking C-spine precautions essentially covers us for all of those problems at the same time. Does that make sense?
Yeah.
Okay, good deal. So ultimately, like you've said, if we're better safe than sorry, and we take C-spine precautions in this situation, we are covering ourselves and protecting the patient, right? In any of those clinical situations. Okay, moving onward. Okay, so obviously, like we've said, the majority of the time, right? We can see these things with concussion, right? But generally speaking, these types of centralizing symptoms and changes are not common all the time with concussion, right? So, what's an example, right? An example of that, as we see in the picture here, is a subdural bleed, okay, subdural hematoma, right? That's a collection of blood, obviously under the dura, as we remember from our lecture last week, which I still have to re-record. I will do that, God willing, tonight after I get back from the airport. But we ultimately, right, we have blood that collects under the dura and ultimately displaces brain tissue, right, and that can lead to obviously neurological dysfunction and in some cases death. um, so we'll see, so ultimately, anytime that we see any of these changes, loss of consciousness, seizure, posturing or rigidity, right, which we'll talk about in a minute, okay, paralysis, um, these types of things, we need to rule out these other conditions before we jump to concussion. Okay, now I want to explain. I want to explain this on the slide here. I say, okay, deteriorating symptoms. Let's talk about what that means. All right. Um, so, what do you think if someone has deteriorating symptoms neurologically? What do you think that might look like? Just guess. If you look at the words, right? Let's say, for example, that we have Susie. Susie's playing intramural basketball, gets hit in the head. There happens to be an athletic trainer there, right? Who pulls Susie into the athletic training room, does an evaluation. Susie's doing okay at first. She has headaches, feels a little bit dizzy. But then, she's in the athletic training room. The athletic trainer is doing the evaluation and finishes, and then goes to do some paperwork, right? And then comes back 20 minutes later and finds that Susie's having obviously increasing headache and starts to go in and out of consciousness, right? Maybe he's having some personality changes, right? So that type of a situation is what we refer to as deteriorating neurological symptoms. Okay. And that should prompt immediate referral to the ED. Okay. Why should that prompt referral? Because remember, yeah, it's definitely true that this could be concussion, but the fact that she has deteriorating symptoms could mean that she could have a subdural bleed, right? The only way to know and rule that out is to get her referred uh, and get imaging done so that we know that in fact that's not the case, right? Um, and we'll talk about the nuances, right, when we talk about concussion. So with a with a typically presenting concussion, all right, as we'll talk about very soon, CT imaging of the head will not ever diagnose concussion. CTs don't diagnose concussion. MRIs do not diagnose concussion, right? And so, however, there are situations in which, like we've said, in these types of symptoms, that we need to cover our butts and rule out other types of pathologies other than concussion here. And we do that by referral and imaging to make sure that there's no fluid in the intracranial cavity. And obviously, we're kind of talking about, could be due to subdural hematoma, spinal cord injury, and or something called central cord syndrome. Okay, let's talk about that. So central cord syndrome, okay, one thing that you guys, and I think I've said this before, but this is super important, okay, there is not ever in a billion years there's no such thing as a bilateral stinger. Okay, we've talked about and we continue to talk about the differences between central and peripheral pathologies. Okay, so in this case, okay, this is an example, okay, of central cord syndrome. So let's say, for example, that we have a football player or maybe a lacrosse athlete, whatever you pick, right? And they're on the field, they take a blow to the head, and the neck hyperextends. Okay, now ultimately, what happens in the presence of such hyper and rapid hyperextension, ultimately the spinal cord becomes compressed, right? Very rapidly from anterior to posterior. As you can see now in this situation in the picture out on top, right? We actually do have damage to the spinal cord here that in this case may result in paralysis, right? But central cord syndrome ultimately, okay, results in a rapid compression of the spinal cord, right, that results in temporary symptoms into the upper extremities. So if you get to the field when somebody goes down, right, you see the contact, you see that hyperextension, and they're down on the field and they don't get up. You're like, son of a gun. So you go out there, right, and you're talking to them. Their ABCs are intact. They tell you, Izzy, I can't feel my hands. My hands are numb. I can't feel my shoulders, my arms. I can't feel a damn thing, right? And so ultimately, in this case, right, this could be central cord syndrome. But regardless of what it is, what do you do here? How do you manage this, guys?
Wouldn't your EAP be activated right away?
Absolutely. Activate your AP, take
That's maybe the
C-spine
word.
precautions, right? Because remember, when we respond, okay, when we respond to non-concussive neurotrauma, we have to cover all of our bases at the same time, right? Because we're not going to know what's actually going on with them until, we get the information either from an imaging study or, further evaluation from the physician. Okay. So we may have a suspicion of what's going on, but the bottom line, in order to protect the patient, right, and protect yourself, all right, activate your AP, take C-spine precautions because there's no such thing as a bilateral stinger. Okay. Generally speaking, right, though, in central cord syndrome or CCS, right, these changes, these symptoms are generally temporary. And let's say that you get into the hospital, they may tell you, oh yeah, you know what? It's actually, by the time you get there, within 30 minutes, it's like, you know what? I can feel my hands now. Yeah, I've got feeling back, you know, and you're like, well, you've got your feeling back. That's great. Even if they get better, you still did the right thing by taking precautions, activating your EAP, right? That's still appropriate care, even if by the time they get to the ED, they're normal. Okay. So try not to be a hero. When in doubt, be conservative and be cautious. Okay. Another sign, right, of potential non-concussive neurotrauma is anoscoria, right? Now, in our case studies, can you guys still hear me okay?
Yeah.
Bingo. Cool. All right. In our case studies yesterday, we had a situation, if you remember, where one of our patients, right, had a pupillary response that was unequal. Okay. So in the example with this patient, right, as we look at her eyes, we can tell, right, she has pupils of unequal of unequal size, right? Now, in a number of people, some people are actually born with a condition like this called anoscoria, right? However, okay, after trauma to the head, so somebody gets hit, same situation. Okay, they take a blow to the head, right? And uh, to your knowledge, they don't have any previous history of anoscoria, and you check their pupils, right? And they are not equal, round, reactive to light. Okay, direct and consensual. That they're abnormal. Okay, what's one of the first things that pops into your head? No pun intended. What's one of the first things that pops into your head with someone that has an unequal pupillary response?
Possible brain bleed.
Bingo. Yes. Beautiful job. Okay. Yep. So, like we've said over and over again, okay, we got to refer to the ED in the event that we see that. Nice. So, one thing that you guys have on your neurocomp, um, and I can clean this up before I post it. Sorry about that. In the event that you have someone that has an dysphoria and or right a pupillary response that's unequal, unless the situation is dire, get a blood pressure. Okay, take their BP. If they're truly bleeding into their cranial cavity, what do you expect to happen? What will their blood pressure be like in the event of a cranial bleed?
Would it be lower?
Yes, that's correct. Why would it be lower, Drew?
My guess would be because a lot of the brain or a lot of the blood is rushing out from the brain, which would cause decreased um, blood pressure in the arteries and veins.
Okay, so ultimately, yeah, you've got decreased ultimately decreased peripheral resistance in the vasculature, and a drop in blood volume in the vasculature as well, because you're bleeding into the brain, right? Cool. Nice job. Yes. So look for that lower. Um, so look for that lower blood pressure, right? Obviously, um, and then obviously, get them referred to the ED if you see that. Okay. Awesome. Okay. Another thing that's really important, guys. Another really important sign. Okay. Posturing and rigidity. Okay, so obviously posturing and rigidity, okay, this can be indicative obviously of a TBI, but posturing itself, right, is characterized by basically sustained muscular rigidity with either flexed or extended upper extremities. And we're gonna talk about the two types here on the next slide. Okay, so here's the thing. Okay, you can see in this picture, all right, that ultimately here his elbows are flexed, right, and his hands are kind of up near his, near kind of near his face. Now, one thing that you need to and I got to tell you guys a story. Okay, this is something that happened to me when I was a brand new athletic trainer. I'd been certified, geez, probably less than a year. Yeah, and I got to be honest with you guys. It's a miracle in this case that I didn't get sued because I didn't catch this. Okay, um, so we had a football game one night, and there was it was a I mean, pardon my language, it was an absolute shit show. We had like 5 concussions that night. And so one of the things too that's hard when you're in that kind of a situation, it's hard to see everything. So I had it was basically a JV or a developmental squad football game. We had a kid come off the field with a concussion. At the time, I was essentially behind the line with another guy that had a concussion and was puking, just sitting on the bench puking, right? And so it was dealing with him, and then another guy goes down, right? And so we pull him off the field, and we get him over to the table. The one thing that I didn't see right away, as he was coming off the field, as we were walking off with him, he was walking, right? He was walking off the field, but he was doing this. His elbows were flexed and his fingers were spread. Okay, so we get him over to a table, and we sit him down, and we're doing an evaluation. And keep in mind, we're also in we're in like rural West Texas, where there's like nothing. I mean, ambulance service. I mean, the nearest hospital is 45 minutes away. Um, and we get him over to a table. We sit him down, and he just blank stare, staring off into the field. And he's sitting on the table doing this. Elbows are flexed, fingers are spread, and literally, I took my hand, I pushed on his hand to try to put his hands down. They went right back up. Okay, so this young man was posturing. So we rushed him to the hospital, right? And I didn't, and guys, I did not catch this right away until it took me a little bit to figure out what was going on. So we took C-spine precautions uh, and got him over to the hospital. But the bottom line, guys, is that this is this is a must not miss, right? And yes, it was a concussion. No, he didn't have no, he did not have a brain bleed, right? Um, but I gotta, guys, this is something that as a young athletic trainer, I was probably 25, 26 years old, but something like this very, very likely could have gotten me sued. Okay. And
So, like, what
so
do you don't not to interrupt? What do you mean you didn't
yeah,
catch it? Like you,
so ultimately been at that one. I, okay, let me, yeah,
it's like, did you
this,
not do? I'm just not. I don't want to interrupt, but did you not do what you were supposed to? Like,
so
didn't you?
I,
You activated the EAP.
right. I did the exam, right. But ultimately when I thought of posturing, Bennett, I thought of this picture only. Right? It didn't occur to me at the time mentally. I didn't think of it that you could still be posturing, have the ability to walk off the field. Right? I didn't catch that. Does that make sense? That's what I'm trying
Yeah.
to say. Right? You can still posture and walk off the field. He literally sat there and was doing this.
Okay.
Okay. Don't miss it. All right. I mean, I could have gotten in a ton of trouble here from a medical legal standpoint. So just be, guys, just be super careful. Okay, be super careful. Um, obviously, we need to monitor obviously ABCs here very carefully, right? And we need to get them referred ASAP. All right. Okay. Types of posturing. So when we talk about posturing, guys, and these are the classic definitions. And remember, like the story I just shared, not everything fits this picture. Okay. That rigidity can be upper extremity only, right? So watch for it. Okay. So classically, though, we describe posturing as being decorticate or decerebrate. Okay. What does that mean? So ultimately, this is generally, and I'm not going to complicate this by putting this on the slide, but ultimately, this has to do with injuries that occur. So decorticate posture generally occurs above the tentorium or above the cerebellum. So the tentorium is a piece of fascia that divides the cerebrum from the cerebellum, right? And so ultimately, decorticate posture, we see that where the extremities are generally flexed, right, and the lower extremities are extended, right, with plantar flexion of the toes. All right. Um, and there's honestly a lot of similarities. Sometimes, as you see in these pictures, sometimes catching the internal external rotation of the lower extremities is not necessarily so much. It's not necessarily so easy to do. It's very subtle. But the bottom line, the dead giveaway here, is the upper extremity position. Okay, so decerebrate posturing, on the other hand, is so we have decorticate, is flexion, and then we have decerebrate posturing, that's extension of the elbows here. Okay, decorticate, decerebrate. Okay, now really. So obviously, anytime that we see this on the field, we would activate the EAP, take precautions, and get them referred, right? Because once again, people, and here's the thing, guys. As a clinician, there are times where things like this, I used to get criticized so much for being too conservative. Coaches would get pissed at me. People would get, well, Wade, you're too conservative. Well, I was like, well, I've been in bad situations before, and I'm not going to essentially compromise, um, you know, my credentials in my career and my ability to provide for my family by making a stupid freaking mistake, right? So I've been there, almost did that one time, right? And I don't want to repeat that. So obviously, with this type of a situation, we need to obviously obviously refer. So decorticate, flexed upper extremities, decerebrate, extended. Okay. All right. So one thing to keep in mind, okay, we get them referred, right? Now, generally speaking, we're not going to see this so much because, right, um, the vast majority of the time, if they actually have a subdural bleed or they have a spinal cord injury, God forbid, right, they're not going to be in our care for a long period of time. Our purpose in that situation is recognition, right, taking precautions, activating the EAP, and getting them referred. Sometimes, though, okay, let's say that the God forbid they have a spinal cord injury, right, and maybe they have a spinal cord injury lesion, right, upper motor neuron lesion potentially, right, and they start off as being really really rigid, right, but as the pathology progresses, right, and actually descends, uh, kind of maybe from the brain and down into the spinal cord and kind of towards those nerve roots, particularly if we have swelling and that type of a thing around the spinal cord, people may display at first rigidity, but then eventually lose muscular control. Okay, so what lesson, right, does that teach us? So ultimately, if we're going to see these types of things, guys, um, or even people that we have referred, it's going to be really important to do serial exams on these patients. Even if they come out of the hospital, they're fine, right? I would still document follow-up neuro exam to make sure that everything is normal, right? That there is um, obviously no continued symptoms. And if you have a team physician, right? If you have a team doctor, have your team doctor see them as well. Okay. One thing that you guys are going to find, and not to speak derisively, but sometimes ER doctors are not the sharpest tools in the shed. Um, you'll get people referred to the ED, and well, we know that they're not going to die, and they're probably going to walk out of here. But okay, I would still, even if they leave the ED with a clean bill of health, I would still get them referred to your team physician, for further evaluation and or, depending on the situation, right, referred to potentially a family physician if you work at a high school. And I would explain the importance of that to mom and dad as well, right? So don't let the ED be the be the be all end all, right? For that situation, really important to examine them again serially, make sure that neurological function is intact and normal, right? But then also make sure that they see the appropriate provider for follow up. Okay, so guys, that's actually the end of the lecture today. I know that that was probably kind of quick, and this is obviously a very brief overview, right? What questions do you have? What questions do you have?
This might be a dumb question, but like in the event that someone like does like in your case came off with rigidity but was able like to get up and walk, or like
Yeah.
someone who like had trauma and then like got up off the field and you like walked them, like how would you then transition into like, would you just have them lay down and then you on the spine board and basically just like
Yep.
spine board
Lovely.
minus the whole like rolling and
Yep.
stuff like that? Or
Lovely question. That's a great question. So there's actually something, and we didn't do this in intro, but there is actually something that you can do called a standing takedown. That's not an MMA move, right? It's actually how you would. It's actually a way to board somebody, right? So with them in a standing position, okay, have them stand still, right? You can actually put them in a C collar while they're standing up. Okay, so ultimately, what I'm saying is, let's say they come off the field, all their stuff is still on, right? You could actually, with them standing, get the face mask off, right, and then actually fit them for a collar while they're standing. Have maybe students or other people on the sideline come in with a board behind you, right? Get them strapped down to the board, and then do what's called a standing takedown, where you slowly lower them to the ground after you've already gotten them onto the board in a standing position. Kind of complicated. Maybe we'll dedicate a class day or two to actually doing that, right? Actually going back through that again. So I know that how many of you feel like, and I know that you guys just did spine boarding on ice uh, like a month ago, something like that. How many of you guys still feel like you need to review spine boarding a little bit more again? Because it's been a minute. Yeah.
Yeah.
Okay. All right. That's completely and totally fair. So I don't know. Does that answer your question?
yeah, it would
Okay.
definitely be beneficial to practice it for sure, because I
Okay.
feel like a lot of instances that I see, at least in like head trauma situations, is they're up and moving because they think they're fine and the adrenaline's pumping and whatever. So
Yep. And this, have you guys ever seen, so like with the stuff that we've talked about today, have you guys actually ever seen posturing or rigidity with a concussion in any situations in your clinicals thus far?
No.
Okay. So like we talked about, not necessarily all that common with concussion, but it can happen. So if you see these things, be smart, refer it. If they're fine, great. You didn't waste your time. You still did the right thing. All right. So, um, any questions about what we've covered? I will get this posted ASAP here, and we won't meet tomorrow because Gustavus says that we don't have class tomorrow. So the one thing I would encourage you guys to do tomorrow is just to review. I will post. I'm going to try to get a couple more things posted for you guys tomorrow, just by way of information about your concussion policy project at the end of the semester that you guys will have, and I'll have some information for you on that, as kind of what that's going to entail, how you can divide up sections, so on and so forth. Okay. Any other questions, friends? Great work today. Thanks for sticking with me through a snowstorm. Cool. All right. Well, if I don't make it home tonight from the airport, it's been nice knowing you. I'm just kidding. I'm totally joking. I shouldn't have said that. But you guys are great. Much love. Okay. And I will see you guys Friday. Friday. We will still be online because it's supposed to still be equally kind of dicey on Friday from what I've been told and what I hear.
Drive safe, Wade.
All right. Okay.
Drive
Have a good day,
safe.
guys.
See you Friday,
See ya.
Wade.
Good Friday.